In this lesson, we will learn about the categories and components of evaluation and management, or EM, services. Understanding EM categories is essential for selecting the correct captain code and is one of the most important topics for the CPC examination and real-world medical coding. Before we begin, this training is for educational purposes only. Always refer to the latest CPT, ICD-10CM, HCPCS Level 2 manuals, payer policies, and official coding guidelines when assigning medical codes. After completing this lesson, you will understand how evaluation and management services are organized into different categories and subcategories. You will learn the various types of EM services and the key criteria used to select the correct category. We will also discuss the difference between new and established patient services and explain how choosing the correct EM category supports accurate captain coding and successful CPC exam preparation. By the end of this lesson, you will be able to confidently identify the appropriate EM service category for different patient encounters. Before assigning any evaluation and management captain code, we must understand the 6 major coding elements. These elements guide coders in selecting the correct EM category and the appropriate code level. The 6 elements include the place where the service was provided, the type of service, the type of patient care, the category of EM codes, the determining components such as medical decision-making or time, and finally the level of service. In the next few slides, we will study each of these elements individually. The first coding element is the place of service. This identifies where the physician evaluated the patient. Different locations use different captain code categories. Office visits are coded differently from emergency department visits. Hospital inpatient and observation services have their own code ranges. Nursing facility services use separate captain categories, and home or residence visits also have unique coding guidelines. Therefore, identifying the correct place of service is always the first step in EM coding. The second element is the type of service. Physicians provide many different healthcare services depending on the patient's condition. Sick services are provided when patients present with illness or symptoms requiring diagnosis and treatment. Preventive services focus on maintaining health through routine examinations and screenings. Emergency care is delivered for urgent medical conditions, while critical care is reserved for patients with life-threatening illnesses requiring constant physician attention. Acute hospital care is provided to admitted patients. Consultation services involve an expert opinion requested by another physician or healthcare professional. Telemedicine allows healthcare services to be delivered remotely using communication technology. Long-term care involves patients who require continuous medical supervision over an extended period. The third element is the type of patient care. In office practice, patients are classified as either new patients or established patients. A new patient has not received professional services from the physician or another physician of the same specialty within the same group practice during the previous 3 years. An established patient has already received professional services during that period. Hospital encounters are classified differently. Initial care refers to the first encounter after admission. Subsequent care includes follow-up visits during hospitalization. Discharge care includes services provided when the patient leaves the hospital. Same-day admission and discharge applies when both occur on the same calendar date. Nursing facility services are divided into initial nursing facility care, subsequent nursing facility care, and nursing facility discharge services. Each category has its own captain code range and documentation requirements. Selecting the correct category ensures accurate coding and reimbursement. After selecting the correct EM category, the next step is determining the code level. Most office and outpatient EM services are selected based on medical decision-making or the total physician time spent on the date of the encounter. Preventive medicine services are generally determined by patient age. Some specialized captain categories use additional criteria defined in the captain manual. Coders must always verify which determining component applies before selecting the final captain code. The final coding element is the level of service. EM codes are arranged into 5 levels. As patient complexity increases, the documentation requirements and physician work also increase, resulting in higher code levels. Coders should always assign the level supported by the medical record, medical decision-making, or time, according to captain guidelines. Let's review the complete EM coding workflow. First, determine where the service was provided. Next, identify the type of medical service performed. Then determine whether the patient is new, established, initial, subsequent, or discharge. Select the appropriate EM category based on the healthcare setting. Determine the code level using medical decision-making or time, depending on CPT guidelines. Finally, assign the CPT code that accurately reflects the documented services. Let's begin with the first EM coding element, which is the place of service, also called POS. Place of service simply means the location where the physician evaluates and treats the patient. Identifying the correct location is very important because CPT provides different EM code categories for different healthcare settings. For example, if a patient visits a physician's clinic for a routine medical problem, the place of service is office or other outpatient. If the patient is admitted to the hospital and receives care while staying in the hospital, the place of service is hospital inpatient. When a patient receives emergency treatment without an appointment for an urgent medical condition, the place of service is the emergency department, commonly known as the ED. Before selecting any EM CPT code, always identify the correct place of service because it determines which category of codes should be used. The second coding element is the type of service. Type of service describes the kind of healthcare provided to the patient. Different medical situations require different CPT code categories. Preventive services are provided to healthy individuals to maintain good health and detect diseases early. These include annual physical examinations, wellness visits, immunizations, and screening services. Critical care services are provided to patients who have life-threatening illnesses or injuries. These patients require constant physician attention, complex medical decision-making, and intensive monitoring. Critical care services are billed using separate CPT codes because they involve significantly higher physician work and greater patient risk. Always determine the type of service before selecting the appropriate evaluation and management code. Let's discuss the next EM coding element, which is the type of patient care. This refers to the kind of evaluation and management service provided during the patient encounter. In an office or outpatient setting, patients are classified as either new patients or established patients. A new patient is someone who has not received professional services from the physician or another physician of the same specialty within the same group practice during the previous 3 years. An established patient has already received professional services from the physician or the same specialty group within the last 3 years. For hospital services, patient care is further divided into initial care and subsequent care. Initial care refers to the physician's first encounter after admission, while subsequent care includes follow-up visits during the patient's hospital stay. Correctly identifying the patient type is one of the first steps in selecting the correct CPT code. Every evaluation and management service belongs to a specific CPT category. These categories organize EM services based on the location and type of patient encounter. For example, office visits have one category of CPT codes, hospital inpatient services have another category, emergency department visits have their own codes, nursing facility services are reported separately, and home or residence visits also have unique CPT code ranges. Once the category is identified, the coder can select the appropriate CPT code based on medical decision-making or time. Choosing the correct category is essential for accurate coding and proper reimbursement. After selecting the correct EM category, the next step is determining the level of service. For most office and outpatient evaluation and management services, CPT guidelines allow the level to be selected based on either medical decision-making or the total physician time spent on the date of the encounter. Medical decision-making evaluates the complexity of problems addressed, the amount of data reviewed, and the risk of patient management. Time includes both face-to-face and non-face-to-face physician work performed on the date of service when CPT allows time-based coding. Preventive medicine services are different. These services are primarily selected according to the patient's age rather than medical decision-making. Always read the CPT code description carefully to determine which component should be used. The level of service represents the amount of physician work and the complexity involved in caring for the patient. Patients with simple medical problems usually require lower-level services, while patients with multiple chronic illnesses, complex medical decision-making, or high-risk conditions require higher-level services. The selected level must always be supported by the provider's documentation and must follow CPT coding guidelines. Assigning a level that is higher or lower than what the documentation supports can result in coding errors or reimbursement issues. Major evaluation and management categories defined in the Captain Manual. Every EM code belongs to a specific category based on where the service is provided and the type of patient encounter. The 5 major categories include office services, emergency department services, observation or inpatient services, nursing facility services, and home or residence services. Each category contains its own Captain code range and documentation requirements. Understanding these categories is the first step toward selecting the correct evaluation and management code. Office sick visits are the most commonly reported evaluation and management services. These visits occur when patients seek medical care for illness, injury, symptoms, or chronic disease management. Office sick visit codes are divided into 2 groups. The first group is for new patients, reported with Captain codes 99202 through 99205. The second group is for established patients, reported with Captain codes 99211 through 99215. Remember that a new patient has not received professional services from the physician or another physician of the same specialty within the same group practice during the previous 3 years. Selecting the correct patient status is essential before choosing the Captain code. Preventive medicine services are different from sick visits because their primary purpose is disease prevention and health maintenance. These visits include routine physical examinations, health screenings, counseling, immunization assessment, and age-appropriate preventive care. Preventive service codes are divided into new patient and established patient categories. New patient preventive services are reported with Captain codes 99381 through 99387. Established patient preventive services use Captain codes 99391 through 99397. Unlike office sick visits, preventive services are generally selected according to the patient's age rather than medical decision-making. Office consultation services are performed when another physician or qualified healthcare professional requests an expert opinion regarding the evaluation or management of a patient. The consulting physician evaluates the patient, provides recommendations, and communicates those findings back to the requesting provider. Consultation services have their own Captain code range and documentation requirements. Proper documentation of the consultation request, evaluation, and report is essential. Emergency department services are provided for patients with unexpected illnesses or injuries requiring immediate medical evaluation. CPT codes 99281 through 99285 are used depending on the complexity of medical decision-making. Critically ill patients who require intensive physician attention are reported using critical care codes 99291 and 99292. These services require detailed documentation and careful code selection. Hospital evaluation and management services include several different encounter types. Initial hospital care is reported for the first physician encounter following admission. Subsequent care is used for follow-up visits during hospitalization. Discharge care is reported when the physician completes the discharge process. When admission and discharge occur on the same calendar day, Captain provides specific same-day admission and discharge codes. Selecting the correct hospital category depends on the timing and purpose of the physician encounter. Hospital consultation services occur when another physician requests an expert opinion regarding an inpatient's condition. The consulting physician evaluates the patient, provides recommendations, and documents the findings. Consultation documentation should clearly include the request, evaluation, assessment, and communication of recommendations. Critical care services are reported differently depending on the patient's age. For patients 6 years of age and older, Captain codes 99291 and 99292 are used. Neonatal critical care services use Captain codes 99468 and 99469, while pediatric critical care services use Captain codes 99471 through 99476. These services involve life-threatening conditions requiring continuous physician attention and complex medical decision-making. Nursing facility evaluation and management services are provided to patients residing in skilled nursing facilities or long-term care facilities. The CPT codes are divided into initial nursing facility care, subsequent nursing facility care, and discharge management. Documentation requirements vary according to the complexity of patient management and medical decision-making. Home or residence services are reported when physicians evaluate patients in their homes or residential settings rather than in an office or hospital. Separate captain code ranges are available for new and established patients. Code selection is based on the documented medical decision-making or total physician time, following current captain evaluation and management guidelines. In the previous lesson, we learned about the different categories of evaluation and management services. In this lesson, we will learn how to determine the correct level of service within each category. CPT guidelines do not use the same method for every EM category. Depending on the type of service, the level may be selected using medical decision-making, total physician time, patient age, payer-specific rules, or the number of days involved in care. Understanding these determining components is essential for selecting the correct captain code. For office sick visits, captain allows the physician to select the evaluation and management level using either medical decision-making or the total physician time spent on the date of the encounter. Medical decision-making evaluates the complexity of problems, data reviewed, and patient management risk. Time includes all physician work performed on the same date, including face-to-face and certain non-face-to-face activities. The coder should use whichever method is supported by the documentation. Preventive medicine services are different from office sick visits. These services are generally selected according to the patient's age because the captain codes are age-specific. Some insurance payers may also have their own coverage requirements for preventive services. Therefore, coders should always verify both the patient's age and the payer guidelines before assigning the preventive medicine captain code. For consultation services, the level may be selected using either medical decision-making or the total physician time, depending on captain guidelines. Proper documentation of the consultation request, evaluation, assessment, recommendations, and communication with the requesting provider is required. Emergency department services use different determining components depending on the type of encounter. Routine emergency department visits are selected using medical decision-making because patient complexity determines the code level. Critical care services, however, are reported according to the total critical care time personally spent by the physician treating the critically ill patient. Hospital observation and inpatient services use different determining methods. Initial, subsequent, and same-day admission and discharge services may be selected using medical decision-making or time according to captain guidelines. Hospital discharge management is generally reported according to the total physician time spent completing the discharge process. Critical care coding differs according to the patient's age. Neonatal and pediatric critical care services are based on patient age and, in some situations, the number of days of care. For patients 6 years of age and older, critical care codes are selected according to the total physician critical care time documented. Nursing facility evaluation and management services are selected using medical decision-making or total physician time for initial and subsequent visits. Nursing facility discharge management is reported according to the physician's documented discharge time. Accurate documentation is essential to support the selected captain code. Home or residence evaluation and management services are provided when physicians evaluate patients in their homes or residential settings. Similar to office visits, the level of service may be selected using medical decision-making or total physician time on the date of service. Documentation must clearly support whichever method is used for code selection. Every evaluation and management service is built around 4 major components. These include history, physical examination, medical decision-making, and total time. Under the 2021 and later Captain EM guidelines, history and examination are still documented but only to the extent that they are medically appropriate. They are no longer used to determine the office visit level. Instead, the level of service is primarily selected using either medical decision-making or total time. Understanding these 4 components helps coders assign the correct EM code accurately. History and physical examination remain important parts of every patient encounter. However, the physician is only required to document what is medically appropriate for the patient's condition. There is no longer a requirement to document a specific number of history elements or examination bullets for office and outpatient EM coding. Documentation should always support the patient's presenting problem and clinical decision-making. Medical decision-making is now the primary method for selecting most office and outpatient evaluation and management codes. CPT divides MDM into 4 levels. Straightforward MDM represents very simple encounters with minimal complexity. Low MDM includes uncomplicated illnesses and limited data review. Moderate MDM involves more complex conditions, additional diagnostic data, or prescription drug management. High MDM represents the highest level of complexity, including severe illnesses, extensive data review, or management decisions carrying significant risk. The physician must satisfy the CPT requirements for the selected MDM level. CPT also allows many evaluation and management services to be selected based on the total physician or qualified healthcare professional time spent on the date of the encounter. Total time includes both face-to-face and qualifying non-face-to-face activities, such as reviewing records, documenting the encounter, ordering tests, communicating with other healthcare professionals, and counseling the patient. If time is used for code selection, it must be clearly documented in the medical record. Medical decision-making, or MDM, is one of the 2 methods used to select the level of an office or outpatient evaluation and management service. MDM is based on 3 key elements. The first element is the number and complexity of problems addressed during the encounter, also known as COPA. The second element is the amount and complexity of data that the provider reviews and analyzes. This includes laboratory results, imaging studies, external records, and discussions with other healthcare professionals. The third element is the risk of complications, morbidity, or mortality associated with the patient's management. Together, these 3 elements determine the overall complexity of medical decision-making. The first MDM element is the number and complexity of problems addressed during the patient encounter. A minimal problem requires very little evaluation. Low complexity usually includes stable, uncomplicated conditions. Moderate complexity involves multiple chronic illnesses or an acute illness with systemic symptoms. High complexity represents severe illnesses or conditions that threaten life or bodily function. The provider must evaluate every problem addressed during the visit before assigning the appropriate complexity level. The second element is the amount and complexity of data reviewed and analyzed. Providers may review laboratory tests, radiology reports, pathology reports, previous medical records, or independently interpret diagnostic tests. As the amount and complexity of the reviewed data increase, the data level progresses from minimal to extensive. Proper documentation of all reviewed information is essential for accurate code selection. The third MDM element is the risk associated with patient management. Risk is determined by the treatment decisions made during the encounter rather than the diagnosis alone. Minimal risk includes simple advice or over-the-counter medications. Low risk may involve minor procedures without significant risk factors. Moderate risk includes prescription drug management or elective surgery with identified risk factors. High risk includes emergency surgery, hospitalization, intensive monitoring, or management of life-threatening conditions. The final MDM level is not based on only one element. Instead, CPT requires that 2 of the 3 MDM elements must meet or exceed the same level. These 3 elements are the number and complexity of problems addressed, the amount and complexity of data reviewed, and the risk of complications or patient management. If any 2 elements qualify for the same level, that becomes the overall medical decision-making level.